Hi guys, I'm happy to join here today. My name is Becca Segrist and I'm a pharmacist here with Cardinal Health. And today we're going to be talking about inflammation and infection imaging. If I can get my slides to advance. Okay, so I am currently employed by Cardinal Health Nuclear and Precision Health Solutions, and several of the views that are going to be expressed in this presentation are the views of myself as a pharmacist and not necessarily the views of Cardinal Health. So with the disclosures out of the way, let's move on to the objectives. So by the end of this presentation, you guys are going to have a major understanding of the steps in the inflammatory process. You will also be able to list the common radiopharmaceuticals that are available for infection imaging. Hopefully you'll be able to describe the protocol for white blood cell isolation and labeling. And finally, we're going to end with a discussion of best practices for ensuring that we maintain a patient-specific process throughout the entire blood labeling. So let's start with a review. I don't know about you guys, but it's been more than 18 years since I've had an immunology class. So let's kind of go over this together. So blood itself has many different components, but we're going to break it down into the parts of the blood that have the greatest impact on the labeling process. So let's start with the plasma. Plasma is the liquid portion of the blood. This liquid serves as the nutritional media and also contains all of the various blood cells and platelets, as well as sugars, fats, proteins, and of course, lots of water. Our next big component is the thrombocytes. These are the platelets that we think about. These are tiny particles within the blood that aid in clotting and coagulation. Perhaps the largest cellular component of the blood are the erythrocytes, or the red blood cells. These typically make up about 40 to 50% of the cellular components, and these act as transporters. They transport oxygen and carbon dioxide in and out of our cells. Finally, we come to the star of our show, which are the leukocytes. These are our white blood cells. They are, of course, responsible for the body's immune response to infection. Now, it's important to note that they only make up 1% of the blood volume. Think about that for a second. The entire thing that our infection imaging protocol hinges on is 1% of the leukocyte labeling. So this single statistic is the cause for many of the decisions that we're going to make within the labeling process. So moving on, let's break down that white cell. It's important that we understand all of the components that make up white cells. They're not all the same. So there's three major cell types that make up these leukocytes. They are the granulocytes, the lymphocytes, and the monocytes. So let's talk about the granulocytes first. Granulocytes have a lifespan from bone marrow of about 6 to 8 hours in circulation and 2 to 3 days within the tissue. We can further break these down. There's three subtypes of granulocytes. So the first that we think about are the neutrophils. So when you hear the word neutrophil, I want you to think first responder. These cells are the first to arrive at an injury site in acute inflammation. So when I fall off the curb or stub my toe, which happens at least once or twice a week, these are the cells that are going to respond first. These cells are really important in chemotaxis and are mediated by lots of different cell types, C5a, C3a. Don't worry about memorizing any of these. I just want you guys to know that they're out there and that they do play a role in leukocyte trafficking and how these cells actually adhere to the vessel walls. The next type of cells that we have are eosinophils. These cells are present in a much smaller percentage, and these are the cells that respond to allergic inflammations, or spring in Oklahoma. So when we have an allergic response, we're going to see a higher percentage of these cells present. Finally, our last type of granulocyte is the basophil. The basophils are responsible for releasing a whole lot of the chemicals that are involved in the inflammatory process. All of those, neutrophils, eosinophils, and basophils, they're all types of granulocytes. Next, we have our lymphocytes. These are the chief immune cells with a large nucleus inside the cell. So you can actually see how large the nucleus is when you examine these on a blood slide. Finally, we have our monocytes. The monocytes are precursors of what we call tissue macrophages, or MACs. These are an important source of those inflammatory cytokines, and we see an increase at an injury site later, and they tend to stay around longer. So when we have something like a chronic infection, we're going to see a larger percentage of these. So don't worry, the inflammatory process is really, really simple. And if we had, a good semester, we could go over all of these. But because we're going to get this presentation done in less than an hour, and nobody wants to sit here for an entire semester, let's simplify it. We're going to simplify it down to 5 major steps. So after an injury occurs, the mast cells kick this thing off. They degranulate, basically they fall apart, and they release prostaglandins and leukotrienes that are responsible for the induction of pain, fever, vascular permeability, and chemotaxis of neutrophils. This is automatically started anytime you have an injury or an inflammation process. So second, the leukocytes then displace to the sides of the vessel injured. We call this margination. And then they adhere to these cells, that's pavementing. Finally, the neutrophils and the monocytes then go through the vascular cell wall and into the tissue at the site of the injury. This is called immigration. So what happens? Neutrophils are attracted to an area. They're going to locate and ingest the invading organism. The monocytes and the granulocytes are going to maintain the surface that that neutrophil binds to. And then the binding of the neutrophil causes an enzyme release. This allows for the digestion of the bacteria and also kills the white cell. Now, anytime we have that, we have dead white blood cells plus the presence of bacteria, this can cause an abscess. And anytime we have abscess and pressure and pus, we definitely end up with a very dangerous situation for the patient. This is how we end up with things like septicemia. So when we talk about chemotaxis, what are we really talking about? We're referring to the movement of a cell or an organism, or even just part of one, in the direction corresponding to the gradient of increasing or decreasing concentration of a particular substance. That's an awful lot of words to talk about. Basically, it's a chemical flag that the cell sends up and attracts these white blood cells to it. So in this case, the cells in question that we're talking about are those neutrophils. Remember, a type of leukocytes. So the infected cell releases these chemical signals. That's why we call these our first responders. Those neutrophils pick up the signal and are going to travel to its source. At this point, they bind to an endothelial receptor and they transmigrate to the side of the cell. So picture it this way. The best way to visualize this is a donut shop that's making fresh donuts. So imagine yourself walking down the street and you catch the scent of that fresh donut. As you follow it, the smell gets stronger and stronger, and then all of a sudden, it's like you're there, you're at the door of the donut shop, so you just transmigrate yourself right on in and eat the donuts, assuming, of course, that the donut shop is not shut down due to COVID-19. So, all right, so let's take a look at our options. When we think about imaging infection, we have 3 major choices. We've been using gallium-67 for almost 40 years. It was the original go-to source for a long time. However, in the 1970s, researchers began taking a look at more imaging options, such as indium-111 and technetium. Technetium didn't really hit the market until the mid-1980s. Finally, in 1988, the FDA approved our final drug, and that's the Tech-99 exametazime. So 3 products: gallium citrate, indium-111 oxine, and technetium-labeled exametazime. So let's talk for just a few minutes, kind of a quick review about these products. So let's start with the gallium citrate. We're not going to focus too much today on gallium because although it is used for infectious imaging, it's not an isotope that we actually use to label leukocytes. However, the historical context and its established roles do merit a brief discussion. So since gallium has been used for over 40 years, no doubt many of us are very familiar with it. Gallium-67 67 is typically dosed around the 5 to 10 millicurie range and has a half-life of 78 hours. It does have poor photo peaks and requires the use of a medium energy collimator that results in less than stellar, shall we call them, images. Also, imaging is delayed up to 3 days post-injection. So gallium behaves like iron, and it's transported in the blood by binding to transferrin. Transferrin is a protein that the body uses to transport iron. Transferrin, right? Once the gallium arrives at the site of infection, it's going to leak across the vascular endothelium and bind to substances that are released by infected cells. So lactoferrin are released by the leukocytes and have iron binding sites. So after the migration to an inflammatory site, again, these neutrophils are going to release a large amount of lactoferrin. Now, it's important to note that because of this process, gallium-67 works independently of the presence of white blood cells. This makes it a great choice for immunocompromised patients who might have a lower white count than normal. Gallium-67 is also indicated for the chronic infections such as osteomyelitis, lung infections, and fever of unknown origin. It's really good for fever of unknown origin because of its ability to assess a broad spectrum of possible causes, including tumors and abscesses and other chronic disease states. So it binds to that circulating transferrin that we mentioned, and it will localize to the liver, the bowel, the kidneys, the bone marrow, and the spleen. It's going to clear very slowly from the blood pool, and we usually see about 15 to 25% of it renally excreted within the first 24 hours. After that first 24 hours, the colon becomes the major route of excretion. It's really important to note this because it doesn't depend on those inflammatory markers, right? So what is it indicated for? It's got several different indications, mostly related to chronic infections. It's also useful in opportunistic infections, such as evaluating the response to therapy in AIDS PCP pneumonia patients. That's pneumocystis carinii pneumonia, commonly abbreviated PCP, because we all know that that's a mouthful to say. So we also see it for drug-induced pulmonary toxicities in patients who have been receiving things like amiodarone or bleomycin. We also see it in other inflammatory processes such as sarcoidosis. For sarcoidosis, we use it to really tell the amount of nodal involvement and stage the lung disease that they've got going on. It's also taken up in lymphomas and lung cancers and the just normal inflammation of wound healing. But because of the elimination in the colon, it's really difficult to discern bowel excretion from abdominal uptake. So this is just an image of what we would see in a patient who's going to test positive for sarcoidosis. Typical uptake pattern here. We see that what we call the panda sign with uptake in the parotid, the salivary, and the lacrimal glands. So, all right, so that's the review of gallium-67. Moving on to indium-111 oxine. Indium-oxine really started to kind of find its audience in the early 80s. The typical dose is in the 500 microcurie range, and its half-life is 67 hours. So similar to gallium in its energy, and the fact that it also requires a medium energy collimator gives those images a pretty low sensitivity. In its function, that's where we really start to see the difference. So how does it work? Indium-111 oxine works because it is lipophilic. So the cell membrane of the leukocytes is made up of basically a lipid bilayer, and then the indium-111 complex diffuses across this membrane. Once inside the cell, the indium-111 is drawn to those subcellular components and will actually separate out from the oxine. The oxine itself is going to leak back out of the cell. So the end result is that the indium-111 gets trapped permanently inside the cell. Because it's got a long half-life and the permanent residency allows for imaging at 24 to 48 hours post-injection. So it is indicated for intra-abdominal infections, again, because the other agents have characteristics can interfere with the imaging of the abdomen. Remember, gallium-67 can appear in the bowels because of its uptake in fecal matter. Technetium, the exametazime, can also leak out of the cells over time and deposit in the intestinal areas. So, now, there are some drawbacks with indium. It actually has one of the higher radiation doses to the patient and a poor image quality associated with those photo peaks and limited availability. So there's only 2 manufacturers of indium-111 oxine, and this is not typically kept on hand at the pharmacies. So if you have a doctor that wants to add on a white blood cell study right away, it's unlikely that the pharmacy would have indium-111 oxine on hand. It's also not recommended for use in pediatric patients. So, all right, our final agent, exametazime. Exametazime really arrived on the scene in the late 80s and quickly became one of the most preferred agents. It's got benefits because it's bound with technetium, which of course has a much shorter half-life than indium or gallium, and an energy peak that really makes it ideal for imaging, resulting in nice, bright scans. It is similar to indium in its mechanism of action in that it's a lipophilic complex as well. The key difference is that it is not stable within the cell, and I mentioned that a little bit earlier. So what happens is it actually slowly leaks out of the cell about 7% an hour. So the fact that it leaks out and doesn't stay in the cells, plus the short half-life, are really key in exametazime's ability to act as an infection imaging agent, and it leads to us having a different protocol for imaging. Typically, exametazime scans are going to be performed same day, usually around 4 hours post-injection, whereas indium is usually we wait until 24 hours later to start the imaging. So it's indicated for use in irritable bowel disease, acute osteomyelitis, and soft tissue sepsis. So for detection of lesions in the spleen, the liver, and a lesser extent in the lungs, exametazime is going to be suboptimal because of its biodistribution. However, uptake in the inflamed bowel is typically well localized within an hour after the injection, but before intestinal excretion begins. So we can really see and detect that through imaging at this time. In the pediatric patients and in cases where we just need better resolution, such as small bowel involvement in Crohn's disease, exametazime is going to be preferred over the indium oxine. So, some advantages, the availability. Again, it's a technetium labeled product, so because the pharmacies are usually going to have technetium on hand, we can get the doses that we need for exametazime relatively quickly and easily. The dose itself is almost 40 times higher than indium, but we see an overall lower radiation dose to the patient and faster diagnosis because, again, we're imaging between 30 minutes and 4 hours post-injection. And there are only 2 manufacturers currently of the exametazime drug, but as I said, we've got the technetium on hand. So taking a look at some images, just some case studies. So the upper left set of images. So this is a set of images for a potential case of osteomyelitis in a diabetic patient who had drainage in the right foot. So image A here on the left shows a bone scan with an increased uptake on the second digit of the right foot. The second image shows the uptake of the tech exametazime. So because we saw it in both places, we have confirmation that this patient has osteomyelitis. The second set is comparing technetium medronate and indium-111. So again, this is another diabetic patient, suspected osteomyelitis. On the first scan there on the left, these are actually 2-hour delay images of the bone scan, and we see an increased uptake in the first metatarsal. Additionally, in this case, the first 2 phases of the bone scan were also positive. On the second image, we see the indium-111 white blood cell scan. We only see 1 positive spot in here due to lack of infection and the lack of the red marrow that we see in the other areas. So, all right, so drawbacks of technetium exametazime are that you have to include that bowel uptake at 4 hours for adults, and it actually shows up at 1 hour in pediatric patients. So you do have to make sure that you're imaging at 30 minutes to 3 hours. So make sure you've got time on your camera to accommodate that. Even with that, it's still an agent of choice for inflammatory bowel disease. So, all right. I wanted to take a few minutes just to review the dosimetry because lately in the last several years, we've definitely seen a heightened awareness for patient dosimetry. So in light of this, let's take a second and compare these three images. So this table represents data that we pulled directly from the package inserts, and some things jump out immediately. So even though there is a wide range of activity among the isotopes, as far as the dose, we still see similar levels of absorption into the red bone marrow and into the liver. Now, interestingly, the highest dose to the spleen actually comes from the isotope with the lowest activity. That's the indium-111. So this phenomenon is likely due to the spleen's involvement with white blood cells. And again, remember that indium-111 is going to stay in the cell permanently until it decays away once the oxine separates off. So just a quick review of the agents. There's a really nice balance that exists in practice among these three options, and each agent kind of has a specific niche. So the decision of which agent to use often comes down to the suspected infectious state and possibly physician preference. So we see gallium-67 used more for the chronic disease states and fever of unknown origin. Indium-111, we tend to see it more for the intra-abdominal images. And then finally, the technetium exametazime gets the nod for inflammatory bowel disease, osteomyelitis, and soft tissue sepsis. So when we compare these agents, if you look at this chart from left to right, it really shows what's better for a chronic infection versus an acute infection. Coincidentally, you can also use this chart to reference the image quality. Image quality is going to improve as you move from left to right across the chart. So, all right, so now that we've discussed some of the physiology and our imaging agents, let's actually talk about the process of the blood withdrawal. We always say that achieving great results begins with great techniques. So what are the things that we really need to consider for a successful labeling of white blood cells? So what things can impact our end results? Patient ID, the timing. We all know that every single patient is different, so patient variables. The actual collection process, what kind of needle size are we using? What additional agents are we putting into this blood sample? And finally, the volume of the sample that we collect. So we're going to actually go through each of these one by one. Again, remember, every single thing that we're doing here is to protect that 1% of cells in our whole sample. So autologous white blood cell labeling, if you've ever taken a close look at the prescription, that's what these prescriptions actually say on them. So autologous just means making sure that we have the same patient through the whole process. So there's several different patient identification options available, but almost every one of them involves some sort of patient identification. Usually it's a wristband. For us, every single blood kit, collection kit that we send out has a Type NX band, and it's going to actually be able to be placed around the wrist of the patient and then has a strip of stickers that can be attached to every single component. So this is an excellent time to maybe stop and review your department protocols. What protocols do you have in place to make sure that your patient that you remove the blood from is the patient that you're about to re-inject into? Maybe it's time to consider some sort of technology. Are you using barcode scanning to assist this? Or are you continuing to use the old style processes, that just involve actually talking to the patient and having them confirm your name? I'm going to use myself as an example of why that can be dangerous. So I actually went to the groomer the other day to pick up my dog. They asked me my name. Actually, they just said, "Hey, are you here for so-and-so?" and named the dog. And I, to be honest, was not paying 100% attention. I said, "Yeah, I paid," and they went to the back to get my dog. They brought out a very cute but very small Chihuahua. Guys, this is my dog. My dog is an 85-pound golden doodle, and in no world could ever be confused with a Chihuahua. But it really just underscores the importance of making sure, we've got the right patient. Maybe that patient's sick. Maybe they don't feel good, and making sure that when we ask them to confirm their name, are they repeating their name back to us? Are we using other things that we have? Are we using barcode scanning to make sure that we don't inject the wrong patient's blood back into that patient? So next, want to talk a few minutes about timing. So we know that the blood cells, the white blood cells, are only viable outside of the body for a limited amount of time. Our current guidance for that is 7 hours from the time it comes out of the body to the time we have to get it re-injected. This will be changing under USP 825. That time frame is going to become even shorter. So you also have to consider, how far away are you from your centralized radiopharmacy that's doing the labeling for you? What kind of travel conditions that may exist? Do you have weather? Do you have construction? And then the actual time it takes to complete the label. It's also important to note that the pharmacy may have other white blood cell labeling processes going in that day. So just because you've drawn the blood, it's always helpful to make sure you schedule that so that there's time reserved to process your blood. The other thing we have to consider is what other studies are going on with this patient. We had a situation recently where a customer had to wait to draw the blood because of their distance, combined with the fact that it was an indium-111 oxine and there were FedEx delays. So when we found out that FedEx wasn't going to be delivering our indium oxine on time, we called the customer and said, hey, can you wait to draw that blood so that we don't impinge on that 7-hour expiration time? So, all right. So let's talk a little bit about patient variables. You guys are actively practicing in the field, so you guys are definitely aware that every single patient is different. So there's lots of patient-related variables that can affect the outcome of a white blood cell study. Hydration plays a really key role. Again, oftentimes dehydration will lead to low plasma blood volume. This can make it really difficult for you guys as you're drawing the blood out of the body. Age can also play a role. Elderly patients tend to have problems, including difficult to find veins, easily infiltrated veins. Also, elderly patients tend to present with hydration issues as well. That's not limited to an increase in age, and we also need to consider hydration status when we talk about pediatric patients as well. Drug regimens. As a pharmacist, I can definitely speak to, we see so many more patients that are taking drugs that can actually impact the white blood cell labeling process. It can contribute to both issues on the front end while we're drawing the blood. Are they on blood thinners or are they on anticoagulants? As well on the tail end when we consider actually imaging. We'll discuss those agents that can cause altered biodistribution a little bit later. We also need to consider patients who are on dialysis. And it depends on what type of dialysis the patient is undergoing. So if they're undergoing extracorporeal dialysis, they should have their blood sample drawn just before they go to dialysis. If you draw it afterwards, you've basically activated all of those leukocytes, and we're going to get a very, very poor tag. Now, if they're undergoing peritoneal dialysis, they can actually have their blood sample taken at any time with no regard to the dialysis schedule. So we know that we've identified the patient. Now we need to actually talk about how we get the blood out of that patient. So the ideal needle size and how we withdraw it, a straight stick is preferred over using an IV line. And we recommend anywhere from an 18 to a 19 gauge needle. Now, that's a big needle, but what we're trying to avoid is damaging those cells. So with a nice big needle size, the cells come out nice and happy. We take a smaller needle size, we're damaging those cells just in the process of removing them from the body. All right, so it's also important that we make sure that we prepare the patient's blood. So due to the presence of platelets, whole normal blood is going to quickly congeal and clot. We want that. That's to prevent the patient from bleeding out if they get cut. However, in white blood cell imaging, that's something we definitely want to avoid. So we add an anticoagulant to make sure that that clotting does not take place. Anywhere from 1,000 to 2,000 units of heparin should be added to the blood upon withdrawal from the body. There are other products out there. You can use ACD. Historically, heparin was used with indium 111 and ACD was used with the exametazime. But there are some issues with the ACD, and heparin will readily work with both agents. ACD in high amounts has actually been shown to be toxic to cells, but as long as we keep it in a 1:5 ratio, usually 1 ml for every 7 mL of blood, we can avoid that toxicity, but you can avoid it altogether simply by using heparin as your anticoagulation unit. Once the blood has been drawn and we've added the heparin or ACD, at that point we want to make sure that we place it needle end up and transport it back to the pharmacy. Now during this period of time, the blood is naturally going to start to settle out. It takes about 30 to 60 minutes for it to settle out. That rate, the rate that it settles, is what we call the ESR, or the erythrocyte sedimentation rate. Now sometimes we get a blood back and for whatever reason, it hasn't settled out. At that point, the pharmacy can add Hespan or hetastarch. Basically, what Hespan is it's a sterile IV solution of hydroxyethyl starch, and it's FDA approved for leukocyte separation. Basically, what it does is it forms cross-links between the red blood cells, which cause them to get heavier and fall out of the solution faster. So the end result is a quicker separation or increased ESR. So this is commonly used, especially if you're really close to your pharmacy. They may not want to wait the full hour for it to settle out naturally. Or you may live in a state, unlike Oklahoma, that has much better roads. For us, the Department of Transportation coordinated with us and made nice bumpy roads so that those blood samples get a good agitation on their way back to the pharmacy. It helps that blood settle out. So how much volume do we need? We're going to send out with the blood collection kit a 60 cc syringe, and our goal is anywhere between 50 and 60 cc's of that patient's blood. This typically results in a sample that's going to give us 20 to 30 cc's of plasma, and that blood plasma is going to be the starting point. That's what we need to separate out. Now, it's important to mention that although 50 to 60 cc's is an ideal amount, it's by no means a strict cutoff point. We can have successful tags when we have lower starting volumes, for a pediatric patient especially. But remember, in our entire sample, only 1% of those are white blood cells. So the smaller our starting volume, the smaller that white blood cell count is going to be. So we do need to make considerations, obviously, for pediatrics. We don't want to draw 60 cc's of a pediatric patient's blood. So it correlates with the age of the child. So the smallest blood personally that I've ever done was with 5 mLs of patient blood. It was almost an entirely blind tag. We didn't actually see the white blood cells as we went, but the end results were that we did get a successful tag. So, all right, you're ready to send the blood back to the pharmacy. So a couple of things just to review here. It's really important to make sure that you put the needle end up because of how we have to remove that separated plasma. If you put the needle end down, the first thing that the pharmacist is going to have to do is to turn that syringe needle side up or tip side up, which is going to undo all of the separation that you've achieved so far. The other case has to do with proper identification. These blood cases have a slide that goes over the top, and it's important to make sure that when you send the blood back and it actually contains a patient blood sample, that that biohazard label is showing. When you receive the kit, that sticker will be on the inside indicating there's nothing biohazard in there, but when you send it back, make sure that that biohazard sign is facing out. So we're going to do a quick overview of the actual labeling process, but I want to define a few terms that you're going to hear as we talk about this. So we talk about the button. What the button is a tiny pellet of material post-centrifugation, basically after we spin it. It's typically comprised of white blood cells, but it also contains platelets, red blood cells, and other various blood fragments. The centrifuge, that's actually a machine that we use to spin the sample at various speeds to help us physically separate the blood component. Finally, the supernate. The supernate of the white blood cells is paramount to a good scan, and that's because we're going to actually use this to help reconstitute the button after we spin it. So again, inside the pharmacy, our process revolves around separating and isolating out those white blood cells. We have to do this because both technetium and indium are not picky. They're going to label any cell that's present, including red blood cells and platelets. So physical separation of that white cell is key to make sure that we get a good scan. Again, we also want to make sure inside the pharmacy that we maintain that proper patient identification. So for the purposes of this demonstration, you can see our patient name there. This is a fictitious patient Sarah Tech, nice little play on words for the name brand of the exametazime drug. But you can see not only do we have the type and X labels there, but we also have a barcode scan attached to the label. So every single step of this labeling process undergoes a barcode scan from separation all the way down to final patient dose. So quick overview of the process. So once we receive the blood sample back at the pharmacy and it starts to separate out, that needs to happen for 30 to 60 minutes. So at that point, we're going to push off that supernate to get hopefully our white blood cells. That's when we really start the isolation. After we push those cells off, we're going to centrifuge it to separate the cells out from the plasma. At that point, then we're going to withdraw the supernate, basically leaving only a button of cells. Now at this point, our button is just general cellular material. It's got our white blood cells, but it's also going to see other cellular impurities. Here's where we can really tell if you drew that patient blood sample with a smaller gauge needle, a 20 or a 23 gauge needle. We're going to see lots of lysed red blood cells in this cell. So we're going to spin it to separate the cells from the plasma, withdraw the supernate. So we should have our button of cells. And you can see there in that bottom image, yep, we've got the button of cells. So at this point, we need to separate out just the white blood cells from our impurities. And this diagram shows a really good picture of kind of what's going on. We're going to use the lysis method. So what is red blood cell lysis? Basically, we are intentionally damaging the red blood cells, causing them to be ineffective. We're going to do this using tonicity. So basically, it's really important to understand the differences between the red blood cells and the white blood cells. The red blood cell wall is very rigid. It doesn't have the ability to flex or to stretch. However, white blood cells, they have the ability to expand and contract like a balloon without damage. So all blood exists in an isotonic state. Basically, you've got equal osmotic pressure, where water can flow into and out of the cell. So if we add sterile water to this blood sample, we're going to create a hypotonic or a low salt, basically, solution where more salt exists inside the cell than outside the cell. What that's going to do is have the same biological effect as you eating super salty tortilla chips. The first thing you're going to do is take a big glass of water to kind of wash that salt out of your mouth. Same thing with the cells. They're going to draw in excess water. Well, that excess water is then going to expand, and because the cell walls are really rigid, it's going to cause them to tear. Whereas the white blood cells, they're just going to expand a little bit, and then we're going to bring them back down to normal size by adding concentrated saline. So the concentrated saline means now there's more salt on the outside of the cell than there is inside, so the water's going to go back outside of the cell. So again, white blood cells, resistant to these changes because of the makeup of their cell wall, so they're going to survive this process while the red blood cells lyse or break open and die. So the number of white blood cells, you can see this is after centrifuge. So we've got our red blood cell contaminant, and we've isolated just our white blood cell button there at the very bottom of that image. So The image, as you can clearly see, we've got a really nice, good white blood cell button, but you do see visually the contamination of those red blood cells. So after that, we're going to pull off those red blood cells so that we just have our white blood cell button. And now we're finally ready to add our radioactive agent, either the indium-111 oxine or the tech exametazime. We're going to let this tag for for about 20 minutes. After that, we're going to pull off any of the radioactive material that hasn't bound into those cells. Finally, our last step, we're going to resuspend this patient's blood with the platelet-poor plasma that we obtained in the beginning. So we're using this patient's very own plasma to resuspend this so that you're going to be re-injecting a volume of anywhere from 3 to 4 mL. So in this particular sample, you can see how it's kind of a almost salmon-colored pink. That indicates the presence of some of those red blood cell contamination. There's only so much that we can get off without impacting the amount of the white blood cells. The typical blood is going to range anywhere from a pale yellow all the way to a salmon pink. So, all right. So we've sent it back. We've re-injected it now into the patient. You've identified that, yes, you've absolutely got the right patient and everything's gone smoothly. But when you get your images back, something's amiss. So what happened? So the outcome of the study is highly dependent on a lot of variables that may not even be related to the actual procedure. We're going to look at a few of these variables that may allow us to anticipate them and hopefully eliminate some of these problems before they become problems. So what are some things that are going to cause an altered biodistribution? So let's take a look at the false positives. So in the case of a gastric bleed, we can actually have radio-labeled blood pooling, misguiding the interpretation of the scans. Also, healing fractures can draw labeled white blood cells to the site, but this may not actually be a site of infection. Also, we need to consider our false negatives. So in the cases of chronic osteomyelitis, we have necrotic tissue, so the white blood cells will never go there because there's not viable tissue for it to be perfused into. So that might be a case where gallium-67 would have yielded a better result. We also need to consider some other causes. And what if the patient's immunocompromised or has immune suppression? Again, they're not going to have enough white blood cells to actually do the study. We already talked a little bit about dialysis and how poor timing can cause a scan to look like a whole body infection. Also, if they're on hyperalimentation, basically they're getting large doses of vitamins. This can mimic an infection. We can also see issues with alcoholic patients. The alcoholism is as part of their disease, it destroys their liver. And again, we should normally see liver uptake with any leukocyte labeling. Additionally, we need to talk about the white blood cell count. Again, remember, we're doing white blood cell imaging. So the normal range for white blood cells is between 4,000 to 10,000 per milliliter of blood. And optimally, to get a really good leukocyte scan, we're shooting for almost 100 million cells. Again, this is one of those things where you might get a call from the pharmacist. If, as we're going through the labeling process and we've done our lysis, if we don't see a visual white blood cell button, the pharmacist may give you a call and just kind of check in and see if there's any other patient factors that might be affecting this blood. Also, patient pathology can impact the study. So if that happens, we can also have impacts with drug therapy. So there are a lot of drugs that can actually interfere with white blood cells' ability to work. Remember our whole discussion about chemotaxis? Well, we have lots of drugs that impact those specific steps. Some drugs are going to reduce the amount of chemoattractant that's released by the cells. So they're not sending up the flags that say, hey, white blood cells, come help. This actually leaves tagged white blood cells circulating in the blood instead of going to the cells where we want them. Other drugs can reduce the amount of neutrophils that we have. That's going to reduce the overall quality of the scan. Finally, some drugs can actually decrease the neutrophil's ability to adhere to the cell wall. Again, that's going to lead with more white blood cells left in circulation. And A lot of these drugs that do this are really common drugs. These are things like over-the-counter standbys like aspirin and Tylenol. So just to sum up, effective communication between all of us professionals can really make great use of this information for determining if a patient will have a problem study or to help us troubleshoot it after the fact if something went wrong. All right, guys, just for further reading information, the package inserts are available for all three of the drugs that we talked about and from the various manufacturers.